for results to come back. Obviously, the numbers are increasing 8 to 10% every single day, so we are seeing this increase. Continue to manage our ICUs, which are getting full right now across the system, but we're in a good place with the capacity at this time. What's more important to talk about is the generosity of the community and the members who are helping Hartford HealthCare and throughout the country, the healthcare individuals. I think the wonderful work of a lot of community members is really well appreciated by all the Hartford HealthCare employees and colleagues at this time. So last week, Ford actually announced it'll produce plastic FDA-approved face shields and distribute them to the hospitals around the country in the need of supplies. So Hartford HealthCare received one of the first shipment of 1,000 face shields, and this is a face shield we received. We are incredibly grateful for the generous donation here. And this mask is it has a plastic film and has a sponge in the back and a strap, and you normally put this in this way to protect any splatter or any other aerosol or anything else coming at your face. It really allows our clinicians and nurses and other members to be able to care for the patients in a very safe way. So I want to thank Ford for this donation. We are also receiving donations on N95 as well, and monetary donations. So we are incredibly grateful for that. Now, regarding the PPEs, this conversation comes up every day. I'd like to remind everybody we're well positioned in Hartford HealthCare. We have secured the supply line, and we are well positioned. But I always want to make sure that the team understands and the folks understand this is all relative. If the numbers go up, our PPE use goes up, and the supply can decline very fast. So we are always trying to stay ahead of the curve and trying to monitor that on that part here. Our supply chain has been working 24/7 with all the suppliers across the globe, and this is almost a 24-hour job for individuals who are making sure they connect with every single supplier, validate the product, look into the product, the right type, and make sure the right type of safe product is allowed in our workforce so that our colleagues are well protected in Hartford HealthCare. We also have a central staffing office, as I mentioned before, who's looking into recruiting anybody who's able to help us out at this time. The respiratory therapists and APRNs and the physicians, our individual environmental services. So we're we're very happy the kind of response we're getting at this time as well. Regarding the social distancing, I had talked a little bit about that yesterday. I do want to make sure that we continue to put this in the forefront here. That is one single factor which is going to help us contain or mitigate the spread of the disease at this time. Social distancing we can do better. We can do better in the state of Connecticut at this time as well. And this is my personal observation. The data is hard to come by, but generally I would encourage all the companies and all the small or big companies, the families and the parents whose kids are home, to really talk about this at home. This is very important for all of us to pay attention. So now I have a pleasure of introducing my colleague and Dr. Sam Pope, who's a director for Hartford Hospital ICU. He has a tremendous amount of responsibility at this time, and he's leading the fight. So I'm pleasure to introduce Dr. Pope. Thank you.
Thanks, Dr. Kumar. And thank you guys for being here. So I'm going to try to go over a bit of our critical care response at Hartford Hospital and then also across the system, and then go into a bit about what we're doing to protect our employees and staff, sort of the inspirational response that they've yielded, and then also want to talk a little bit about our ventilator capacity, since that question continues to come up. So I am Sam Pope. I'm the director of the medical ICU at Hartford HealthCare, or at Hartford Hospital for Hartford HealthCare. We knew very early from looking at what had happened in Italy and then the early sort of outcome in Washington State that we were in for a fight with this. And so we actually started to plan quite a long time ago, which seems like a long time ago, but was only about a month ago. But we started to plan for what our critical care footprint would need to be with this, not only in Hartford Hospital, but across the system. And so we came up with a tiered system that we would try to enact that rolls out our space utilization, the way that we would utilize our staff, including advanced practice, our residents, our nurses, PCAs. Like, this actually takes a lot of people to make this work, because we would like to deliver the exact same level of care to our patients that we're delivering before this happened, even with this very severe surge of extremely ill individuals. So we have a tiered system for that, and we have been progressing through that. The system is certainly strained, and we have met that challenge thus far, but we know that we're in for more challenges ahead, and so we are certainly planning to continue to roll on this path as best we can. I can tell you that this has not been done just through the medical ICU personnel and staff. In Hartford Hospital, I know that our surgical critical care colleagues, the cardiology critical care colleagues, our anesthesia and anesthesia critical care colleagues, advanced practice, nursing, all the people from the other units have been instrumental in helping us to make sure that this has been done in some way that seems strategic, well thought out, and safe for everybody involved. We certainly are ready for what comes at this point, and I do want to recognize all those people who've been involved. I want to move on a little bit and tell you guys about our ventilator capacity, because I do know that a lot of people have asked me this question, friends, family from around the country. There's a lot of talk about this in the media. I've even had a number of people who have sent me, pictures of 3D printed objects to utilize multiple, or one ventilator to ventilate multiple individuals. We are well resourced at this point across the system. That doesn't mean that there's limits. All these resources are finite, and so we need to protect them. But I will tell you all that we so far have been very good at sort of rolling out our resources and our utilization with the need. The need is going to increase, and so we continue to work on this diligently. And there's a daily email that comes out about 6 a.m. from one of our respiratory therapists who's been a yeoman in terms of work with this. And so we know what the utilization is across the system, and we can plan accordingly. We have gotten very creative, I will tell you, in how we can utilize some of our devices that wouldn't normally be used in this way to ventilate patients who are very sick. And we haven't had to use those yet, but we're certainly ready to do so if need be, including ventilating multiple patients with one single ventilator if the need arises. So I think we're well resourced, and I want the community to be reassured that we're ready no matter what happens. And finally, I want to talk a bit about our PPE usage. I know this is also in the media. There's a lot of fear in the community, and I want to reassure everybody to just please find good sources of information and try to allay that fear. I mean, this disease is spread by droplets in contact, similar to flu, not exactly. Of course, none of these viruses are exactly the same, but I would encourage you to look at good resources by the CDC. Hartford HealthCare also has a lot of resources at the homepage. You can reach out, but we've been very methodical in trying to think about how to protect our staff in these critical care spaces. So we have certainly continued to use N95s where necessary. That's where there's a lot of aerosolization of material on patients who are on ventilators or who are having procedures done. And also thinking about trips into the room. So we've gotten very creative about using long IV tubing to keep the IV pumps outside the room to limit the number of trips in and out. And we're trying to look at ways to use our ventilators in the same fashion so that we can control the ventilator from outside the room, thereby limiting the number of exposures and risk from patients. I'll also say our anesthesia colleagues have done a lot of work trying to limit exposure to their individuals, because maintaining your workforce is critical in this situation. So I'll stop there. I'll tell you we're gonna get through this, and we're gonna get through it and be stronger on the other side, but there certainly is going to be some pain. So with that, I'd like to introduce Dr. Henry Anyamadu from our central region in the Division of Infectious Diseases. Thank you.
Thank you all for coming and for listening to us. So I would start by talking about the hydroxychloroquine and chloroquine that was recently approved by the FDA. So the FDA issued an emergency use authorization for hydroxychloroquine and chloroquine. And these are medications that we've known and have experience with for many years, for decades. They've been used as anti-malaria and hydroxychloroquine and chloroquine are not completely benign. They can have some side effects. We did receive these authorization with some bit of skepticism because these medications haven't been proven in a randomized control trial. Yes, we are using them out of desperation because we do not have anything else to use. So we are continuing to use these medications in these patients. There is some scientific rationale to consider these medications, and the rationale is that the hydroxychloroquine and chloroquine can inhibit or interrupt the replication of the virus. But as I said, this is only limited to a very small human studies that was done in France. And in that study, they just used about 20 patients. It was about 26 patients. And it's been heavily criticized by the scientific community because it was an open label, it wasn't randomized, and the surrogate endpoint for the study wasn't really validated. But as I said, we're using these medications out of desperation. But I will caution clinicians out there and people out there who are trying to use these medications because we don't have robust data. And the FDA emergency use authorization was actually for select hospitalized patients. So these medications are not out there to be used by anybody. We've had questions from clinicians out there and some patients who are asking whether they can use these medications to prevent acquiring COVID-19. Unfortunately, at this point, there's no data to support that. And the idea of using chloroquine and hydroxychloroquine to prevent COVID-19 is predicated on the fact that it can interrupt viral replication. But I will tell you that the scientific community is not approving the use of hydroxychloroquine and chloroquine to prevent COVID-19. At this point, we don't have any data at all. So I wouldn't want to propagate a false sense of hope that we have a cure or we have a robust treatment for COVID-19. What we really need to do is to listen to our public health officers who are advising us to stay home and maintain social distancing. At this point, I'll open it up for questions for any of us.
Yes, Emily Brindley from the Hartford Current. Could you just explain the circumstances under which you would use that medication to treat patients? You said select hospitalized patients. What types of patients?
I would have Henry answer that. Thank you.
So mainly these are patients who are hospitalized who are in moderate to severe conditions, especially patients in the ICU, patients who are intubated on a ventilator. So those are the kind of patients that we would use hydroxychloroquine in combination with probably azithromycin to treat these patients.
Doctor, have you seen, sorry, Bridget from the Republican American, have you seen a successful reversal or improvement in those patients?
So that's difficult to say because we've had patients who received hydroxychloroquine and azithromycin and went home. However, we've also had patients who have actually had a patient who died whilst on these medications. So at this point, it's very difficult to say that these medications are efficacious or are helpful in these patients. But yes, we are using them because we don't have anything else to use. There are some other investigational medications that are being studied, including remdesivir that we've all heard about, and there's tocilizumab as well. and other medications that are being investigated. So there is hope in the future, and in a very, I think there's hope out there that we can really look forward to. But at this point, we do not have a robust medication to treat these patients.
Dr. Bridget from the Republican American again. Can you give us the sort of pedestrian understanding of what happens in the sense of a severe patient going downhill? What happens in the ICU that becomes irreversible to that patient as the disease overtakes them?
I will have Dr. Pope answer this question.
Yeah, so I can tell you guys, we don't understand exactly at this moment why some people have very, very minimal disease or almost no disease, totally asymptomatic with this. But of the people who deteriorate, there definitely is a progression where people develop low oxygen levels, so we have to use supplemental oxygen to keep them up. And then sometimes this progresses very rapidly, even overnight. And China actually performed a lot of CAT scans on these people, and we have done CT scans on some as well. And you see this viral pneumonia that then progresses to what we call adult respiratory distress syndrome. So there's this scripted, outpouring of inflammatory proteins that become malignant all on their own and sort of create secondary damage. And so some people have this happen, and it does transpire even over 12 or 24 hours for some of our hospitalized patients who end up on the respirator. But once that process starts and you end up in that place, we know that it's going to be a struggle for you to make it through. We use different techniques to try to ventilate you, which we have been discovering, thankfully, over the last 15 years that limit our mortality. But this disease in particular is particularly nasty for those individuals who have this very severe response.
Hi, can you explain the recovery process for some patients? It doesn't seem to be linear. It seems like some people get worse before they get better, or there's a real sort of unpredictable nature to the recovery process. I'm wondering if you could talk about that a little bit.
Yeah, there's definitely been some discussion, certainly within you guys will know, like a lot of our medical journals have produced some content over the last couple weeks that has been very instructive. I mean, all of us have reached out to colleagues in Italy, Washington, New York, people who've lived through this. But there is this sort of bifid peak to the disease for a lot of people who end up in the ICU. So we end up on a respirator. People seem to do better over the first few days, and then there's this second wave that comes. At this point, I hesitate to, make any kind of conjecture about what that might be, about whether it's some, viral replication that's going on, or if this is more of an innate immune response that's gone out of control that starts to attack you. I think it's probably going to be more the latter, just based on what we see with other septic patients. But there is sort of this twin peak, and it often gives you this sense, even our patients that we've had in our hospital who've been there the longest, they seem to get better, and then there's this worsening that occurs that sometimes will go along with markers of sepsis, so blood pressure drop, renal failure, that is not from some secondary infection. Certainly these people are at risk of those things as well, but there definitely is a second wave almost in a lot of patients.
Good morning, doctors. This is Catherine Loy from NBC Connecticut. Slightly off topic, but wondering if you can just address the census. Today is Census Day, and how that funding impacts you guys, especially in a public health crisis like this that you can't predict.
I'm going to let Dr. Kumar take that.
The short answer is really don't know at the moment. I think there's a lot of discussion about supporting the healthcare industry and various industries happening at the moment at the state and at the country level, but the details are still not out there. I'll try to give an example of a very simple thing. We rolled out a large telehealth network across the system right now in e-virtual console. We're able to support our patients, the existing ones or the patients who are requiring some help at this time who are unable to commute for whatever the reason. we don't know actually how we're going to get paid for that at the moment. So I think there's a lot of unknowns at the moment. I think the healthcare industry, at least in the Hartford HealthCare, we are really we're trying to figure this out, that how do we continue to support the community and to be in the front of this battle as much as possible, and hopefully with the finance side and other things we'll deal with that. I can tell you that every single institution in the country, healthcare or otherwise, is seeing the financial challenges, and they're going to continue to see over the time. But how this fundings and other census-related information is going to shape into that, it's too early to tell at the moment.
Dr. Kumar, this is Emily from the Current again. I'd like to ask about the model that Hartford HealthCare is working with MIT on.
Yep.
And I know that you said earlier that it likely won't be released until early next week. But I was wondering if you could compare it a little bit to the University of Washington projections. Those project about 1,100 deaths in Connecticut by August. Can you say at this point if your model is predicting more deaths or fewer deaths in the state?
So I wouldn't be able to comment on the deaths, but I'd like to explain to you the different models and how the variables they're using right now. So there's the Penn model, and there is a Washington model, and there's a few other models out there actually, and they all do a reasonably good job, but I don't think any model at the moment can really truly predict where the peak is going to be and where the mortality is going to be. The reason is the variables which are included into the modeling, it's the infectivity rate, which is how frequently are we going to infect each other, and that is completely dependent on social distancing. That's why I go back to that part here, and that's a human behavior. That's unpredictability we're living with right now. The second part is that the travel part, which we have restricted very well, but still any kind of travel which is happening, as you know, in all the states across the country right now, we still don't have that strict social isolation or social distancing process right now. So there's a lot of variability happening in our country, which is making the models very difficult. The other part is about the number of testing we're doing. Unless we do large amount of testing, and we understand epidemiologically how the disease is proliferating in the community or how it is affecting, the models actually come short of declaring the exact number. So we looked into all the different types of model, and we are working with MIT right now to put as much as possible in this time. The infectivity rate, the length of stay of patients staying in the hospitals, ICU. We're looking into the process of the demographic, how old people are living, what is the age range of the people in Connecticut, and so on and so forth. So we're hoping to come closer to the data as good as we can make it, but there's always going to be an error here, which actually is going to be difficult to predict. Our goal is to predict when the peak is going to happen, and when the peak happens, how sustained the activity is going to be, especially in the ICU and critical care area, because that is the bottleneck we're concerned about at the moment. The second part is mortality. Mortality is obviously very important for us to know, but that is dependent on how stressed the hospitals and the supply chain is going to be to a certain extent. And that is how we want to protect our healthcare workers and healthcare colleagues in that part here. So these models are dependent on a lot of somewhat unknowns, unfortunately, at this time. So I would not be able to comment at this time what the mortality will look like in Connecticut. Surely the trend we have seen lately is concerning. We have not seen a slowing down of the disease. And as it's been talked about by the White House at the moment, the numbers are staggering. And so this is continues to be a concern for us.
And do you still think that the model with MIT will be released early next week?
Yeah, we are hoping a special media presentation on that part right now. We've been working on that. The model requires some validation, as we talked about. Some of the variables we're including at the moment. The data is coming very fast, and obviously we're looking into a variety of different data sources. And I do want to preface the fact that even the MIT model, with people working with Hartford HealthCare, it may not be an entirely accurate model. It depends a lot on other factors which are not in the control of the simple math.
Great, thank you.
Hi, this is Jocelyn Lamenta from CNH.
Yep.
What is your policy regarding N95 masks for staff dealing with patients who are COVID positive and or showing symptoms?
So, our policies is very much CDC guided by at the moment. The individuals who are using the N95 mask are obviously working in the high-risk COVID positive area, who are exposed to the aerosolized procedures Dr. Pope was explaining earlier on, people who are intubating the patients and all that. But I do want to make sure that for media and everybody who's listening here, our Hartford HealthCare's position has been to protect our colleagues as much as possible within the supply and everything else we have. So we are ready to serve the community. And we're well positioned on that part here. I do hesitate to go down to the details, especially in the media presentations about exact policies, because I'm not entirely sure the information is captured appropriately and transmitted. I think that what the community needs to hear, the media needs to hear, well prepared, we're protecting our people, we're going to continue to do so. Any other questions?
Doctor, you already have addressed this question largely, but if we are to see 1,100 deaths by August, that would be low by the federal estimations of 100 to 240,000 deaths across the country. Do you think that number is high? And that number is based on current social distancing guidelines?
The numbers, I would not comment on the number at this time because I still don't know the number for sure. What I would tell you that the Connecticut has done moderately good job in social distancing so far. And if they continue to do that well over the several weeks, I think our numbers could be looking better than what we've been thinking about at this time. I think this is going to test our patience to a certain extent, how well we are able to manage the social distancing. But the national numbers are staggering. And as you know, we live in a small world, unfortunately. We're affected by everybody's action. So despite how well we do in Connecticut, if the neighboring states or the states across the United States are not performing to the level or not keeping the social distancing as much as possible, there is a possibility, and if not now, in 3 to 4 weeks or 5 weeks or 6 weeks, that we have a migration happening of the virus in a different area, and we might see the hot zones coming up. So that's the problem we have right now with this virus, that we might contain in a social and a localized geography right now, but the long-term possibility of coming back to the hot zone and making the mortality looking different is very real possibility. So I think what we need to do as a country right now to really follow the social distancing and really hunker down at this time to contain as much as possible. And that would be the best predictor at this time.
This is John Memento from News 8. A quick question on the National COVID-19 Convalescent Plasma Project. Are you one of the 34 institutions in the country taking part, getting blood plasma donations from recovered patients?
Not at this time. We've had some conversations about that. We're still evaluating, but we're not at this time.
Thank you.
This is Catherine from NBC Connecticut. I was wondering if you could just touch on testing. You had mentioned widespread testing a few minutes ago.
Yep.
Does that play a role in how you're going to predict when this is going to peak? And I know New York is prioritizing healthcare workers in terms of testing. Is that something that we're doing here, considering here?
So we are, in Hartford HealthCare, we are prioritizing healthcare workers. We're prioritizing, obviously, on inpatients and most vulnerable population, as we talked about, based on some risk factors such as age and chronic disease and other factors. We're doing as well. The problem we have right now, we don't have enough viral test medias, and if we don't have the VTMs and the swabs, we cannot test mass. I think if we had more media, the right thing epidemiologically to do is test widely, test very widely in our community, so we can isolate how the proliferation is happening, what the denominator is, and how we actually target individuals within a small community or larger community about therapies, whether it's a quarantine or whether it's exposure to the healthcare facilities and things like that. And that trend, the data point is extremely important for us to predict in future. Some of the challenges we've had, at least in my opinion, this is my opinion, in the United States, that we have not been able to predict very well when the peak and the sustainment of the peak will happen, only because we don't have a widespread capability of testing. And unless you do the study in the mass population, you don't get the good data. And that's the challenge we have.
Hi, this is Sierra with the New Britain Herald. How are you?
I'm doing very well.
I just have a couple questions.
Mm-hmm.
My first one was, it was reported by the New Britain mayor that they had their first death at the hospital due to COVID-19. Would you be able to tell me any additional information, maybe the gender or the age of that patient?
No, I would not be able to comment on that. I'm sorry. These are careful considerations, so I would not be able to comment on that.
Okay. Earlier you were talking about PPE and procedures and protocols.
Mhm.
Do you guys have anyone or a group that kind of oversees that for each hospital? I know you talked about Hartford Hospital itself, but
Yep.
does anyone go check at the New Britain Hospital or the other ones in your system just to make sure that everyone has what they need and everything's being taken care of properly?
Yeah, so I think we have really organized very well in that part here. Just to kind of give you a bit of a inside view of how we work, we have incident command, which actually meets every single day, every single day, 7 days a week, which actually manages all the parts of the organization, an entire 30,000 people, all the access point of more than 400 in Hartford HealthCare, all the 7 hospitals, the community network, the home care services, our rehab centers, our SNFs, and assisted living. So entire Hartford HealthCare network is reported up to the incident command. Incident command makes a decision about the supplies, the policies, the procedures, and we roll this out in a cascading way across the system. So we have a very good understanding of exactly how the different parts of the organization is working. We've divided ourselves in several different areas. So for example, the facility is looking into the scalability, the supplies and all that. In my role, I look at the clinical side, what needs to be done, how the spread or the focus is in how we're protecting everybody else. Similarly, the PPE, the policies and guidelines or rollout is managed differently. The supply chain is working to support differently. It's a very tightly knit program which we're rolling out. Every single unit, like Hartford Hospital or Central or East, has their own incident command center. So what gets rolled out is managed across the system as well. All the clinicians and the nursing input is sought in those meetings, and that's escalated. So the bi-directional model is we decide is what the epidemiologically we need to do based on all the capacity we have, and the feedback from our people is about what's going on the ground so we can optimize our process as well. And so far, when we started the process in January, our actually incident commander has done a good job, and I take a lot of pride in that we made the decisions of whether it's a visitor policy or restricting visitor policy even further, our travel bans, restricting it further, our PPE deployment effort, our education for all the individuals, how do you don and how don off, how do you do the fit testing, all those measures we put together have been sequential, methodical, and thoughtful, and somewhat disciplined. And that is one of the reasons I can say confidently the Hartford HealthCare is well planned out this process for some time to come.
Okay, and my last question is, how are, the nurse techs and everyone who has direct contact, being protected and treated and supported? I know you said there was a shortage with tests, but are they able to get these tests if they're really telling whoever's in charge that, they're feeling these symptoms and there's something going on with them?
I think your question, if I can rephrase, is that if any of our healthcare colleagues requires a test, can they get a test? We have an algorithm. We look into the appropriate setting, the symptomatic, and there's a triage criteria, and based on that, we test everybody. As you know, the flu is still out there, and we always worry about the possible common cold as well, and the variety of seasonal allergies and things like that. So for me to say that everybody who wants a test gets a test is probably not correct. But everybody who deserves and needs a test gets a test in Hartford HealthCare.
Yes, that's what I meant. Like if they came in direct contact with maybe a patient who had the COVID-19 or was suspected, they would be able to get tested.
Yeah, we're guided by our infectious disease experts advising us what the right strategy is, and we follow that very strictly.
Okay. That's it. Thank you.
Thank you very much. I appreciate everybody's time. And before I close, I do want to make sure that you do write in your publications and journal thanking and recognizing all the members of our community. Thank you.
Thank you.
Very good. Thank you.